Good afternoon, everyone. Our group number 2 is going to start case presentation. General data, patient Mr. X, who was 8 years old, gender male. Chief complaint, there was severe itching, watery eyes, and photophobia. History of present illness, patient came to the clinic because of severe itching, watery eyes, and photophobia. Visual acuity is 6/6 in both eyes. Reddish eyelids because of frequent rubbing. Several raised fleshy lesions are noticed on the conjunctival surface of both right and upper eyelids. Review of systems, general, there's no fever, chills, malaise, myalgia, fatigue, nausea, or vomiting. In skin system, there's no rash, but there's color change, itching, and visible lesions. In ophthalmology system, there is no blurring in the vision, there is no pain, but there is epiphora, which is an excessive tearing. There's redness of eyelids, and there is no cataracts. In neurosystems, there is no headache, no dizziness, blackouts, numbness, vertigo, no orientation changes, no slurred speech, no forgetfulness, and mood changes. In past medical history, the patient is currently on treatment for asthma. As far as allergy is concerned, there's no known allergies reported. Personal and social history, there's no information provided. Family history, there's no information provided. Physical examination. On examination, his visual acuity is 6/6 in both eyes. There's redness of eyelids noted. Conjunctiva is mildly injected on both sides. Cornea are clear. Several raised fleshy lesions are on conjunctival surface of both eyes, and upper eyelids are noted. Salient features. Patient age was 8 years. Visual acuity is 6/6 on both eyes. There's severe itching, photophobia, watery eyes, redness of eyes, and there are several raised fleshy lesions on conjunctival surface.
To see the initial impression of our case. Our initial impression is vernal keratoconjunctivitis. So why we consider these initial impression is vernal keratoconjunctivitis is most commonly occurs in young boys who often have a personal or family history of atopy. Most patients fortunately outgrow the condition during their puberty. So the characteristic features of this condition is severe itching of the eyes, watering, and photophobia, and mucoid discharge occurs. And signs tend to occur either under the upper eyelid or around the cornea. Now we will see the differentials of this initial impression. We took 3 differential diagnoses of our case. They are acute allergic conjunctivitis, viral conjunctivitis, and atopic keratoconjunctivitis. Now coming to acute allergic conjunctivitis, this is a conjunctivitis is common condition caused by a reaction to an environmental allergens, like for example you see pollen and all. So it typically seen in younger children after playing outside. So the characteristic features are like itching and watering, like that. And why we ruled in is we can see the pinkness or redness of both eyes, watery discharge, swollen eyelids, and photophobia. And we ruled out this condition by this burning, itchy nose, sneezing, and scratchy throat, which are not seen in our patient. Now coming to viral conjunctivitis, this is a common external ocular infection, mostly caused by adenovirus. So the spread of this highly contagious infection is facilitated by ability of viral particle to survive on the dry surface for weeks. Now, why we ruled in is we can see the redness, watery discharge, itching, and photophobia in our patient, and we ruled out this condition by blurry vision, tender periocular node, burning sensation, and pruritus, which are not seen in our patient. And now coming to the atopic keratoconjunctivitis, we can say it is generally like vernal keratoconjunctivitis, but the main differences comes here is this is seen in the patients of at age 30 to 50 years. Generally, vernal keratoconjunctivitis leads to atopic keratoconjunctivitis in their later ages. So the symptoms are mostly similar to the vernal keratoconjunctivitis. And now we ruled in this condition by these symptoms like watery discharge, itchiness of the eyes, and photophobia. Now we ruled out by burning, and Denny Morgan folds and keratinization of lid margin, and we never saw the head-hook sign in our patient.
The final diagnosis is palpebral vernal keratoconjunctivitis (VKC). Now, moving on to the discussion of palpebral vernal keratoconjunctivitis, it is basically affecting boys. The onset is at an age which is more than 5 years. So, our patient is basically 8 years old, so he is susceptible to this. It is a recurrent bilateral disorder. Also, there is the interstitial inflammation of the conjunctiva of periodic seasonal incidents that's usually due to some exogenous allergens. The classification is basically palpebral, limbal, or mixed, but here in our patient, he's experiencing palpebral VKC. Now, moving on to the pathophysiology of VKC. VKC has some predisposing factors, which are young age, the climate, which is summer, and tropics, because in temperate regions, it's rare. Now, moving on to the pathology, there are various ways to explain the pathology. Firstly, there is the marked cellular infiltration of the adenoid layer. Then there's hyperplasia of the conjunctival epithelium, and the fibrous layer has experienced proliferation, which could lead to hyaline change. All these lead to the multiple papillae, which are seen in the vernal keratoconjunctivitis. The symptoms are basically marked burning and itching sensation, mild photophobia and lacrimation, and heaviness of lids. Now, the associated signs and symptoms as linking to the case are severe chronic ocular itching, photophobia, palpebral form, basically because here we are seeing the typical cobblestone appearance, which are nothing but the raised fleshy lesions, which are bilaterally seen. Also, there is redness of eyelids, the conjunctiva is mildly injected, or there is hyperemia, and the watery eyes. Now, we'll be proceeding to the management of VKC. The management is basically divided based on the severity. So, for mild cases, they may respond well to the topical antihistamines and artificial teardrops, although the additional of topical mast cell stabilizers and oral antihistamines is often required in cases of moderate severity. Severe cases frequently require short courses of topical corticosteroids such as fluoromethanolone or dexamethasone, in which case the intraocular pressure needs to be monitored to detect and treat a rise in the pressure which should occur, if it may occur or not. In very severe cases, if we see, there is the topical immunomodulatory drugs, which are cyclosporin and tacrolimus, which may be needed to control the inflammation. Moving on, we'll continue with the management. Here is a division of what are the things a patient should we should keep in mind. First is the general measures. There should be allergen avoidance, cold compress, lid hygiene. For the topical treatment, we have topical antihistamines, artificial tear drops, cold compress, mast cell stabilizers, combined antihistamine and vasoconstrictor, NSAID preparations, also topical corticosteroids. Lastly, we move on with the systemic treatment, which is oral antihistamine or antibiotics. So, thank you. This sums the case.